Hi, everyone. So I guess we'll get started. And my name is Wenji Wang. I'm one of the transplant nephrologists and the medical lead for the Living Donor Program in Calgary here. So I'm glad to have a joint session between Calgary and Edmonton today. So before we get started, we'll do the land acknowledgement. We acknowledge that University of Calgary, located in the heart of southern Alberta, both acknowledge and pay tribute to the traditional territory here of the people of Treaty 7, including Blackfoot Confederacy, the Tsuut'ina First Nation, and the Stoney Nakoda. City of Calgary also homes to the Métis Nation of Alberta Regional 3. And this seminar was sponsored by Paladin, Stella, and AstraZeneca for their support to the ATI series. So it's my great honor today to introduce our speakers, both here in Calgary, Dr. Ngan Lam and Dr. Halpin from Edmonton. I don't think we need much introduction for Yang. She's been a excellent transplant nephrologist in both Edmonton and Calgary. Thanks to Dr. Robert Quinn, we were able to poaching her to Calgary. So she's associate professor at the Cunnings Medical School in Calgary here, and a clinical scientist in both the division of transplant medicine and nephrology. Her research program really focusing on using the healthcare administrative data to improve the process and outcome of most related to the living kidney donors and kidney transplant recipients. And Dr. Halpin is the Edmonton group are probably more familiar with her at the role of director for the HL lab in Edmonton. But today, I guess she will share her perspective as an anonymous donor. She donated kidney back in 2002, and we'll hear her firsthand experience with that. So without further ado, today's title is Living Kidney Donation Perspectives and Outcomes. Dr. Lam.
Thank you, everybody, for joining in person and for those online, and for the ATI for allowing us to present. I'm just going to get us started that we don't have any conflicts of interest. We won't be discussing any off-label use of drugs or devices. In terms of the agenda for today, we're going to start with Anne. She's going to give us her donor perspective. I'm going to go through some background and then talk about risks to the donor, which is going to be the bulk of the presentation today, and then our next steps in Alberta. So I'd like to hand it over to Anne.
Thanks so much. Nang, would you mind going to the next slide? That's a really big picture of my face, so we don't need that up there very long. I hope everyone can hear me okay in the room there.
Yes.
Yeah, awesome. Thank you. It's so strange for me still to be speaking as a donor and not talking about HLA or ABO. So bear with me as I'm still honing this discussion for myself. So my donor journey began with a friend in need, and the person on this slide is probably pretty familiar to a lot of us watching in the room or online. So this is a picture of Sean, who many of you know through Alberta Transplant Institute or previously Canadian Blood Services, and Sean needed another transplant, and I, as an HLA person, knew that we weren't a match. Most living donors wouldn't know their HLA. Most living donors wouldn't know how to do a virtual cross match, but I knew that we weren't a match, and so many people came forward as potential donors for him. And at the 2019 Canadian Transplant Summit, which was a joint meeting between CST, CDTRP, and CBS held in Banff, he gave a really wonderful talk about his journey and how so many people had come forward, but none were actually able to move forward as donors for one reason or another. And it really got me thinking about, what maybe I could do to help. You can go to the next slide, please. So, at the same meeting, there was a great talk from Dr. Dori Segev. I used pictures here that were a bit more fun than slides from a photo. Dori also acts as the official DJ for the ASHI end of meeting networking events. And so you can see him here working hard as a DJ and with his like DJ badge on his speaker, his meeting badge. But at that meeting, the same 2019 meeting, he also talked about outcomes of living donors. And I kept looking at these slides and thinking, well, I'm in that line of people who have the best outcomes as a donor, or that for me, based on what we know, not a lot of Canadian data, although Nang has some data that she's going to share, but still the data he presented were typically, I think, mainly American data. But I just kept looking at these slides thinking, I think this could be a really safe thing for me to do. And this is really helpful for me to see this information, even though I'm, he's not presenting it to me to say, and I'm not sure he knows what a big role he plays in my decision to proceed as a donor. But that meeting, for those two talks that I saw at the meeting, really got me thinking. Can you have the next slide, please? So I phoned the living donor office and I said, I wanted to be considered as a donor for him, but that I already knew we were virtual cross-match positive. And they said, why do you think that? And I said, because it's Anne from the HLA lab, so I know this. And so there was a lot of blood work and more blood work, x-rays, CT, ECGs. In my case, also a pulmonary function test because of something that was seen on the x-ray and CT, which turned out to be fine. But all these tests throughout the whole process, you do, especially for me with the lung results that needed to be investigated a little bit, you do, start to worry a little bit, like, I hope nothing is wrong. I hope that nothing is found that's actually, a problem, because probably everyone listening knows better than I do how thorough these tests are. And Nang's going to talk about safety for donor a lot in her talk as well. But there's a lot of tests, and so it is a little stressful sometimes because you worry, what if something is there? What if there's a problem? But in my case, I was really lucky. There was no issues that were detected. That's a picture of me sitting in the blood collection chair. So this font is not super easy to read here, but what it says here is, my friend found a compatible match. So even though it was a bit hard for him because he had antibodies, not so many that he was advantaged in the sensitized sort of way, highly sensitized patient registry way, but he had this wonderful human came forward with a match, a friend of a friend, and he was transplanted. If you can move to the next slide, please. So here's a picture of Sean and his amazing donor, Brenda. And so, when Sean called me to say, I have a match, and I was so excited for him. And, I was off the hook, but I'd already made some pretty big decisions about proceeding to do this as a paired exchange donor for him. So I had some thinking to do. And one of the things I had to really think about was, for me personally, in my experience anyway, is how much does this connection to a recipient matter to me? And, in this process, because now if I was going to proceed, it would be as an anonymous donor. Although I did send a very strange email to a previous colleague who I knew had renal disease in his family to ask if anyone in his family needed an A kidney. They did not. But those are some of the things I had to think about. What does this matter to me? Is this, how do I feel about being an anonymous donor versus being a donor that's directly connected to someone? At the end of the day, I decided to proceed as an anonymous donor, but I always do really still think of Sean as my donor inspiration. And if you can go to the next slide, please. So I donated. There were some hiccups along the way. My surgery was moved once. The recipient, this was through kidney paired exchange cycle. So there was a match somewhere in Canada for my kidney. That person went in for their surgery, and there was found to be something on the ECG that needed to be investigated. So I did have one sort of stop and reschedule. Timing is tricky as a living donor. If you're, for anybody, whether you're working or parenting or all of the above, any other different, Jenga things of life. And so I was fortunate that I could move my timing. Did have a little bit of tight timing with my PhD defense, but in the spring of 2022, I proceeded as a donor. I was also very lucky that my employer, Alberta Health Services, or Alberta Precision Laboratories, is a member of the Living Donor Circle of Excellence, which meant that I didn't have an interruption in my salary. That's a very big deal for me, and I'm sure many other donors. I was also lucky that my recovery was really straightforward, and my dog was most concerned, I think, of anyone in my family about how I was doing, and she was kind of on me like glue. You can see her here sitting on my lap, just like looking up at me, like, "Are you okay? What's going on?" But yeah, I was able to get home quickly. I was able to get back to walking and doing a lot of things cautiously, but pretty quickly. You can go to the next slide, please. So I did not have any changes. I don't have any changes to my daily life. I do now have a nephrologist. That was an option for me from the program. I know that's different from center to center. It's something that I think Ngan will also be touching on. I do definitely think about transplantation through a new lens now. I've had worked for decades as a histocompatibility laboratory technologist and lab scientist, now director in training, just hopefully finishing the end of that journey. But it definitely has given me some new food for thought about how I think about transplantation, how I think about what we do in the lab every day. And I'm still sort of navigating that new lens a little bit. Yeah, oh, and also I got great gifts from people like that cup on that slide. I have a wonderful village. Thanks, Nang, for going back. Yeah, it says, I don't know if you heard it says, of course I donated a kidney, who wouldn't want a piece of this? And someone custom made that cup for me and I still love it. So things that I think about now as a donor, and some of these things are going to come up at the end of the talk for future directions. I think about how well matched was I to my recipient. I don't know this. I don't know my recipient. They don't know me. But I honestly think about this probably more than I think about anything else with regard to my recipient, which is again an HLA thing, probably. Maybe not a typical donor, maybe doesn't think about that as much as I do, but I definitely wonder that. I wonder, is there more I should be doing to protect my renal health? I definitely am drinking more water. I continue to, have the same healthy practices I had before my donation, but if there was something specific I should do, I would want to do that. And I don't know that we necessarily know all those things. I'm very grateful to have a nephrologist, but I always wonder, like, is all the testing being done? Is an eGFR sufficient? Should there be more GFR testing like was done before my donation? I don't think we know necessarily. And is this testing should be tailored to individual donors, more personalized? I wonder about capturing data across Canada, on living donors, because we have CTR, it's a great registry. We don't, for patients or donors, we're not capturing a lot of things. And I know because I use that registry in my job, I know it exists. And I wonder about, are we underutilizing that as a tool? I also wonder, we have all these amazing tools. I threw iBox up here as an example. I'm not sure if that's supposed to have a R or a TM behind it or something, but, are there tools that we should be developing for donors and not just recipients that use AI and other things to say, what is the risk for the donor? Can you go to the next slide, please? Other things I think about, I was very fortunate, as I mentioned, that my wage was covered. I was like the least, I literally work in the building where my workup was, except for the pulmonary function test. I did have to go somewhere else, but, I didn't even realize that donors pay for parking. I think that's something we're going to be resolving soon, but, all these kinds of things that, how can we make it easier for donors in their workup? My family was very supportive. I will say that not all of my friends were super encouraging. And I wonder if more public awareness of, translating to the need for living donors, the safety for living donors would actually have, meant that I didn't encounter that some people who were sort of saying, like, I think you're crazy, I don't think you should do this, which is hard to hear when you've made a big decision like that. Vouchers, like meaning that you could sort of have a pay it forward as an anonymous donor for future use. This is a system that's in place in some other places. I know someone who donated recently through Mayo, Arizona, and she was given a voucher, which she actually immediately used, which, sort of felt like she was getting to double her donation. Not an option for me. Would this kind of safety net, though, increase the number of anonymous donors? One of the things that a lot of people have said to me is, well, what if your kids need a kidney someday? What if someone else in your family needs a kidney someday? And I felt comfortable to proceed knowing the wellness of my family and no history of renal disease, but those are legitimate questions. And, at the end of the day, this was an easy choice for me. And I just wonder, how can we get more people to make this choice? Would better prediction of donor risk translate to more living donors? So that's, I think, my last slide, Nang, if you move to the next one. Yep. All right. Thanks.
Thank you, Anne, for that So I'm going to just talk a little bit about the background of living kidney donations. So living donor kidney transplants performed in over 90 countries, and Anne was one of 35,000 living kidney donor heroes that donate every year, and it makes up about 40% of all the kidney transplants that we do in the world. This is a slide from the Canadian Blood Services. You can see how Canada in the red matches up in terms of their living donation rates compared to other countries. So we do pretty good. We're behind the US, but ahead of Australia, Spain, and the UK in terms of rates per living donor rates per million population. And if we look at different provinces across Canada, you can see that Alberta actually does pretty good as well in terms of living donor rates per million population at 16. We're kind of comparable to Ontario. So what are the potential benefits of a living donor kidney transplant for the recipient? Well, compared to deceased donation, a living donor kidney transplant offers better patient and graft survival and better quality of life. There's the opportunity to shorten or avoid completely dialysis time. It's also a planned elective procedure that we can do when the donor and the recipient are optimized for health, rather than the kind of midnight call-in for deceased donor offer that we sometimes do. You can get sometimes better HLA matching if the, I know this makes Anne excited, but if the donor and recipient are related, you can get better HLA matching, which can improve rejection rates, and also reduce cold ischemia time, which would reduce delayed graft function. And in terms of benefits for the healthcare system, there's reduced costs. So it's estimated that every donor saves the healthcare system about $200,000 over 5 years. So that means every 100 transplants we do saves the healthcare system about $20 million. So that's a lot of money. So I'm going to talk about the risks to the donor and try to present some data from Alberta as well. In terms of mortality risk, it is a surgery, so we do quote donors a small risk of mortality. From this large US study, the risk of mortality after a donor nephrectomy was about 3 per 10,000, so 0.03%. So very small, but not zero, and much less than the risk of a lap chole, which is about 18 per 10,000, and non-donor nephrectomy, which is about 260 per 10,000. This was a study that came out in 1997 looking at long-term mortality. This was by Dr. Fairman Ekholm, who herself is a living kidney donor as well. And she looked at expected survival of donors versus the general population. You can see that donors live longer than the general population. And this was very exciting, but not all that surprising, because donors are a healthier subset of the population. They go through an extensive testing and assessment that Anne talked about. And we only let really healthy people donate. So it's not surprising that they do better than the general population. So when we look at studies, we're looking to compare living donor outcomes to a comparable group. So as I mentioned, the living kidney donor population is a much healthier subset of the population. And when we're looking at outcomes, we want to have a comparable group to compare outcomes to. So what we've done in the past is a process of restriction and matching. So basically we take the entire general population in our databases, and we exclude anyone that might have medical comorbidities that would potentially exclude them from donations, such as diabetes or cancer, lung disease, if they've had gestational diabetes or preeclampsia, if they've had a previous nephrectomy or biopsy, or if they've seen a nephrologist in the past, if they've even looked at nephrologists in the past, we excluded them from the study. And then what we're left with is a, somewhat comparable, healthier non-donor population that we can then match to the donors based on variables such as age, sex, and income, and then look at the outcome of interest. And that's a much more appropriate, comparable group to compare outcomes to. So in a similar vein, this was a study from the Norway group, and they looked at all-cause mortality in living kidney donors and healthy matched controls, and using a similar process that I just described. And you can see here that in the first 10 years, the mortality in donors and healthy matched controls is actually pretty similar. Lines are almost right on top of each other. But 15 years after donation, you can see that the lines actually start to diverge, such that overall living kidney donors appear to have a higher risk of mortality when you compare them to healthy matched non-donor controls. In terms of kidney outcomes, so this is what we get asked a lot about in the donor assessment. So we actually did a study where we looked at 604 living kidney donors in Alberta, and we matched them to 2,414 healthy non-donors in the general population, and looked at blood work done for kidney function and their eGFR over a median follow-up of about 7 years. And you can see the donors, which is the solid line, have initial drop in their eGFR after donation, about 30 to 40%. But then after that, their average change of kidney function over time is actually quite stable, about plus 0.32% per year, whereas the non-donor population has kind of an age-related decline in their kidney function, about 1% per year. There have been some studies that have looked at kidney failure in the donor population. So this was one of the first studies from 2014 from the American group looking at almost 100,000 living kidney donors and compared them to healthy matched controls. And they also found that compared to healthy matched non-donor controls, living kidney donors appear to have an increased risk of kidney failure over time. This risk of kidney failure appeared to be higher in certain subgroups of the donor population, including older donors, male donors, and Black donors compared to white donors. But again, when you look at it compared to the unscreened general population, the risk of kidney failure is lower compared to the unscreened general population, but does appear to be higher compared to the healthy matched non-donor control group. In terms of how this happens, this is a hypothesis, a multi-hit process hypothesis about how donors could potentially get kidney disease and kidney failure. So you can see that the dark line is the general population, and over time, your kidney, as you get older, your kidney function decreases over time, again, by about 1% per year. And the idea is if you develop a second hit, say at age 50, that could change the trajectory of your kidney function. And the thought is with donation, where you have that immediate surgical drop of 30 to 40%, that kind of puts you at a lower kidney function. And then if you do okay, post-donation, but if you develop a second hit, say developing hypertension or developing diabetes post-donation, that could potentially change your trajectory and put you at increased risk of kidney failure. So again, this is the American group that looked donors who had developed kidney failure over time. And you can see that, so these are the kidney functions of donors who developed kidney failure. And you can see that for the majority of these donors, they had pretty stable kidney function, but then developed a secondary hit, such as the development of hypertension or diabetes. And you can see that for a lot of these donors, that changed the trajectory of their kidney function, leading to kidney failure. So how do we help donors make this decision about whether or not they're at increased risk? I don't know if Wenji, if you use this or if anybody else uses this when we do our donor assessments, but there is this prediction model that you can use, that I use when I assess donors. And they looked at 7 cohorts of non-donors. And this is predicting the risk of kidney failure in a donor candidate if they do not go on to donation. So you can add in, their characteristics here. So this is a 40-year-old female who's white, has a kidney function about 90, no hypertension, no diabetes, and their risk if they don't donate would be about 0.04% over 15 years and 0.3% over their lifetime. So very low risk, less than 1% risk of developing kidney failure if they don't donate. On the same vein, there is another prediction model that helps predict what the risk of kidney failure if they do donate. And this is based on 5 variables. So again, the same 40-year-old female who is not a first-degree relative to their recipient. And it gives you their risk of developing kidney failure if they do donate. So you can see that at 15 years, the risk of developing kidney failure would be 0.07, which, if you remember, is slightly higher than the 0.04, but still overall very low, less than 1%. And to me, and I hope to donors, that that's reassuring to them. In terms of other outcomes, so a notable outcome that was published in the last decade was looking at pregnancy outcomes in female living kidney donors. So this was a study done by the Ontario group looking at 131 pregnancies in donors, 131 donors, female donors who had pregnancy, and looking at 788 non-donor pregnancies. And they looked at the outcome of gestational hypertension and preeclampsia. And what they found was that donors had a higher risk of gestational hypertension and preeclampsia compared to non-donors. Overall, about twofold increased risk. But again, the numbers are quite small, about 5 to 10% compared to 2 to 5%. So what we counsel donors is that compared to healthy matched non-donors, the risk for donors is that they may have an increased risk of mortality, they may have an increased risk of kidney failure, and they may have an increased risk of pregnancy-related complications for female donors. But what we stress is that these are increased relative risks and that the absolute risk is very small. We can't say zero, but is very small. What about other outcomes? The Ontario group also looked at cardiovascular outcomes, so death and major cardiovascular events and major death censored major cardiovascular events. And you can see that compared to healthy matched non-donor controls, those lines are pretty much right on top of each other. So living kidney donors do not appear to be at increased risk of cardiovascular events compared to healthy matched non-donors. And when I was there, used to have done a number of other studies looking at other outcomes such as kidney stones, risk of GI bleeding, risk of fractures. And again, you can see these lines are right on, pretty much right on top of each other. So no increased risk in donors compared to healthy non-donors in these outcomes. So we thought these results and these studies were reassuring for the practice of living kidney donation. So again, just to summarize, living kidney donors may have an increased relative risk of mortality, kidney failure, and pregnancy, but there doesn't seem to be an increased relative risk of cardiovascular disease, fractures, GI bleed, or kidney stones. Now, a lot of these studies have looked at single system diseases and single system organ outcomes. But as we know, a living kidney donor can develop multiple diseases throughout their life, putting them at increased risk of kidney or cardiovascular events. So this is a study that we're currently working on. It's not published, but we do have preliminary results, which we also presented at the CST this year as well. And the purpose of this study was to look at what is the comorbidity and multimorbidity burden in living kidney donors, which has not been previously well looked at in the literature. So what we did was we did a cross-sectional studies of all living kidney donors who were alive and residing in Alberta between April 2019 and March 2020, and had donated between 1994 and 2019. We looked at various comorbidities and multimorbidities, including cardiac, kidney comorbidities, and other. I'll go through those. So when we looked at cardiac comorbidities, so we had about almost 1,000 living kidney donors in Alberta at that time, so about 979. And the majority of donors did not have any of the cardiac comorbidities that we looked at. About 65% of donors did not have any history of cardiac comorbidities. You can see the most common cardiac comorbidity was a history of hypertension, of which 31% of donors had a history or current hypertension. 7% of donors had current or history of diabetes, and about 5% of donors had a risk of or had history of major cardiovascular events, which we defined as heart attacks, strokes, or TIAs. You can see here from this Venn diagram that about 5% of donors had both hypertension and diabetes, and 1% of donors had all three of these comorbidities. When we looked at kidney comorbidities, reassuringly, the majority of donors did not have the kidney comorbidities that we looked at, which included low EGFR, which in our study we defined as less than 45, two measurements separated by 90 days apart, and proteinuria, moderate to severe proteinuria. The most common kidney comorbidity that we found was a history of kidney stones, which was present in about 12% of the donors. We also looked at other comorbidities, and the most common comorbidity that we looked at was a history of or current depression, which was present in 36% of donors, followed by chronic pain, which was history or present chronic pain was there in 32% of donors. 11% of donors had a history of cancer, and 5% of female donors had a history of hypertensive disorders of pregnancy, which was actually a bit lower than what the Ontario study had. We looked at the number of comorbidities based on age, and you can see that almost 80% of donors had at least one of the comorbidities that we looked at. And not surprisingly, the older you got, the more likely you were to have multimorbidity, which we define as more than 2 or more comorbidities. If you were a 50-year-old donor, your chance of having 3 or more comorbidities was about 33%. So a third of donors over 50 had 3 or more of these comorbidities. And we think that these results can help guide follow-up care by maybe identifying a subgroup of donors that would most benefit from periodic health review. So we've talked about all these risks to the donor. Again, overall, the risks are low, and we think that most donors do well because they're selected to do well. But we do recommend follow-up care in order to keep an eye on donors and possibly prevent bad outcomes from happening, and also to inform them of a new literature that's coming out about donor outcomes. So for example, when that study came out about the women having an increased risk of gestational hypertension or preeclampsia, women who had donated prior to that study may not have known that they were at increased risk. So follow-up care might be an opportunity to inform donors of new research coming out about their potential outcomes. So the international guidelines, the KDIGO guidelines, do recommend that living kidney donors see a doctor once a year in order to get annual follow-ups. So that would include measurements of blood pressure to monitor for hypertension and BMI to monitor for obesity, serum creatinine with eGFR measurement to look at their remaining kidney function, and also albuminuria testing to check for protein in the urine. And the recommendation is that donors get this done kind of once a year after donation. So what is our current transplant policies in Alberta? So in Calgary, the Living Kidney Donor Program does have a surgical follow-up at 2 to 4 weeks post-donation. And then a letter goes out to the family doctor and to the patient as well, recommending that the donors get this annual follow-up with their family doctor. But we don't really track to make sure that this is actually happening. And but donors are able to call back if they do run into problems. In Alberta, the Living Kidney Donor Program, again, arranges the 6-week post-donation follow-up with the surgeon, and there are labs done around that time as well. At the 1-year mark, the Living Donor Program also arranges to have the approving nephrologist see the donor with labs at that point as well. And then at that point, ongoing long-term follow-up is arranged and discussed kind of as a shared decision-making between the donor and the recipient, between the donor and the nephrologist as to who will be following that donor, whether or not that's the family doctor or whether or not that's the nephrologist. So there is the opportunity to follow up annually with the nephrologist in Edmonton if the donor chooses to. I know this talk is mostly a living kidney donor talk, but I don't want to exclude the living liver donor program. So the living liver donor program in Edmonton, their follow-up policy is to, again, arrange that surgical follow-up within 6 weeks with labs. The living liver program also sends out recs to do blood work at 3 months, 6 months, and then the living liver program follows them once a year for about 10 years. And at that point, I believe they're discharged to their family doctor. They also arrange an abdominal ultrasound at 1 and 2 years to monitor the liver. So this kind of gives you a feel of what different kind of follow-up policies are with the different living organ programs in Alberta. So we wanted to know, well, these recommendations came out that living kidney donors should get annual follow-up. So we wanted to know, well, how often is that actually happening in our living kidney donors? So we looked at, we did another study where we looked at living kidney donors and how many of them had all three of a physician visit, a serum creatinine measurement, and an albuminuria testing, and each year of follow-up after they donated. So again, this is the percent of follow-up care and then post-donation year after they donated. So we had 534 living kidney donors that we looked at between 2002 and 2014. And you can see that after donation, living kidney donors are seeing a physician. About 90% of the donors every year after donation are seeing a physician, which is great. But where we fall short is only about 60 to 70% of the donors are getting serum creatinine and albuminuria testing every year post-donation. And when we looked at how many donors are getting this every single year after they donate, which is what the guidelines recommend, only 25%. So 1 in 4 donors are getting what the international guidelines say are the recommended care for donors after donation. And we did look at center kind of region specific as well. And the living donor follow-up care in terms of guideline concordant care was better with the Edmonton donors than it was with the Calgary donors. So, you know, we have the Edmonton living kidney donor group that arranges the 1-year follow-up. The Calgary group does not have a mandatory follow-up with the nephrologist. The Edmonton group does. What is the US doing? Well, the US mandates that transplant programs have follow-up data on their donors at 6 months, 1 year, and 2 years post-donation. So the transplant programs in the US have to follow or have follow-up data on their donors for at least the first 2 years. So another question we had, well, if you have early guideline concordant care in the first 2 years, does that actually change your outcomes? So this was a study done by one of our internal medicine residents, who is now a nephrology fellow, actually. And we looked at the living kidney donors in Alberta. We saw we compared those that had all 3 of those guideline concordant measurements. So physician visit, an albuminuria visit, or a creatinine measurement and an albuminuria measurement in year 1 and year 2, and compared them to those that did not have that in the first 2 years. And you can see that the line, the dark line on top, which is the donors that had that early guideline concordant care, they were more likely to have continued guideline concordant care post-donation compared to the donors that did not have that early guideline concordant care. When we looked at other outcomes, there didn't seem to be any change or difference in eGFR, the kidney function, between those that had early guideline concordant care versus those that did not. So, and there also was no change in hospitalization rates overall. So what we took from that is if you have early guideline concordant care in the first 2 years of your donation, you're more likely to have continued guideline concordant care, but maybe it doesn't change significantly outcomes such as your kidney function or your hospitalization rates over time. Overall, I'm a big advocate for living kidney donation and protecting living kidney donors from bad outcomes. You know, I believe that these heroes undergo an invasive medical procedure that's not for their own health. And I think we as a transplant community do have an obligation to our donors to ensure that they remain in good health and have good outcomes post-donation. So with that, I'm going to hand it back over to Anne, who's going to talk about the Alberta Transplant Institute and our kind of what we came up with in terms of research priorities with the Alberta Transplant Institute.
Thanks, Thang. I was really honored to work with Dr. Lam on this, helping to, and the team that was assembled, who all contributed to setting research priorities in living donation as part of the Alberta Transplant Institute. I think we had really a fulsome discussion of, many different things. We had lots of different, areas of interest. And in the end, it was actually, I think, pretty, I think we came to a really good consensus of sort of choosing a top 3 of things that we would want to highlight for research priorities within this group. So I think the first one, if you want to click, Ning, so increased awareness of donation was something that came up pretty continuously in our conversation for a number of things. Obviously, for anonymous donors, would need to be more awareness, but even for awareness within people who are seeking support from within their friends and family group, to have more of an awareness of what living donation entails and what's possible. If you can click again. Long-term outcomes, Dr. Ngan just gave a great overview of what we know, what we don't know, and having Canadian, specifically Alberta data, but data that is applicable to our local donor populations is really, really important, and also to understand long-term outcomes to help people make informed decisions about being a donor, with some level of granularity as well, hopefully for their specific characteristics. And then finally, improve follow-up care. Nang touched on this, that even within our single province, there are some differences. And I talked about when I was saying, I was really happy to have the option to have a nephrologist, especially I think right now in Alberta, where finding a family doctor isn't necessarily possible or easy. My own family doctor is retiring soon, and I'm already worried about finding another one. So I am very relieved to have that continuous care for myself personally. And I guess the other thing that's really nice now is that there were some silver linings to the pandemic, and one of them is definitely that we know we can have virtual visits. We don't have to necessarily travel for that care. So those were the three top priorities that were identified. There were others, of course, but choosing a top three, these were the three that sifted to the top in our discussion, and we had a pretty democratic voting process for identifying those as well as a group. And I think I think that was the last slide. So thanks so much for letting me talk today, and thanks for that great overview. I will say none of that made me nervous as a donor, looking at all those statistics. I felt like I was also given a lot of information as part of my workup as well, which I appreciated. So I think having more information is better, not worse, for sure, for people in decision making and understanding their risk. And I think that's our last slide.
That's great. Thanks, both of you, for a very inspiring talk. So I guess while everybody typing their questions, I have a question for Anne and Yang. First, for Anne, during the workup process, any of the time moment you were a bit of wavering or wobbling? Is there any moment like that? And I know it's such a long process, right?
Yeah, and my process was a little COVID interrupted because it was all like it was in that sort of challenging time. I didn't, but as I mentioned I have the I guess having worked in the peripheral to transplant, or as part of from the HLA perspective of transplant for a long time, maybe I had more background information than some donors would have. But as I mentioned, I definitely had a few people, and I will say they were actually healthcare people, not general public people, who said, I don't know that you should do this. I don't know that this is a good idea for you. Those moments didn't make me change my mind, but they didn't feel good, and they weren't from people specifically nephrology. So it made me kind of irritated also, because I thought, I spent a lot of time understanding my risk, and my nephrologist as part of the workup, and the amazing coordinators as part of the workup answered questions for me throughout the process. So it wasn't that I felt a wavering or any hesitancy, but it was more just something I had encountered, and that I had to sort of educate them to say, this is safe for me, or I wouldn't do it. And I can also say that even if I knew that there was, I was going to be in that small percentage, it's way in the future for me, I don't know that would have made me, this has really benefited my life. I feel a huge, it makes me so happy when I think about this. So that's a harder thing to quantify, as to, what is the benefit for the donor. But I'm glad I did it, and I feel like it's made my life richer. So yeah, I hope I answered your question. I didn't really feel a wavering, but definitely I encountered some pushback, I guess, a few times. And I did discuss this also very carefully with my family. And there was no concerns from my family, but if there had been, that would have been a definitely something to consider in my thought process.
Great, thank you. My question, I didn't see any, you mind. My question to Yang is, I'm glad that Alberta follow-up data are quite encouraging. The old follow-up data always suffering a significant lost follow-up. Out of those 900, do you have any idea, Yang, how many of the patients left, like the entire donor pool left Alberta may not have the follow-up data?
Yeah, so there wasn't a lot. I'd have to go back and look at our cohort, but there wasn't a lot of people who had immigrated from the province. One of the great things about our data is that it's healthcare administrative data within the Alberta Kidney Disease Network. So we're able to capture all donors as well as all blood work done anywhere in the province, any prescriptions filled anywhere in the province as well. So we're not missing out on information in that sense. I do know the immigration rate of just overall, just the general population is less than 2% per year leave the province. So it would be a very small number of donors, I would think, that would have left the province that we wouldn't have data on.
Are you able to see the questions coming in online up on the screen? Or from Jan or from Donna?
I can read Jan's question out if you don't see it.
Yeah, go ahead, Anne.
It says, so Jan has asked, my son donated a kidney to me 5 years ago in Calgary. Should I recommend to him that he be having more follow-up care? He has had none regarding his kidney care since 6 weeks after his donation to me.
So in Calgary, as I mentioned, donors would have had the follow-up post-donation surgical follow-up at about 2 to 4 weeks, and that's all donors. And then a letter would have gone to the patient and to the family doctor recommending annual follow-up care, which I mentioned, to see a physician, get your blood pressure checked, get your serum creatinine done, get your proteinuria done. And so that is what's recommended. And so in Calgary currently, that is really put back on the family physicians and to kind of arrange that. And obviously, if there's any concerns from the family doctor or from the donors, we make it very clear to everybody that donors can call us back and follow up with us if there's any concerns. I'll just put this plug in. We are trying to more formalize, have a dedicated follow-up care clinic for donors in Calgary to improve the follow-up care. So that is something we're definitely working on based on some of the research that we've done. So I guess in answer to your question, yeah, the recommendation would be to have follow-up care, either through the family doctor, or if there's any problems or concerns, they can always call the Living Donor Program back, and we are more than happy to help living kidney donors.
Another question in the chat was from Donna. I don't want to say the last name wrong, Veldhoven. And her question is, what type of support from friends and family would you want? That might be directed at both of us. How could we change your experience positively? Education, public awareness, maybe. And in the chat, I had said, I think public awareness would help. I think it's one of the reasons that this sorted to the top as one of our research priorities in our discussions. And her follow-up question is, public education to come from what group? Public health, transplant services, CTA, policy developers, patient groups, or ATI? I think all of the above, because they might hit different targets. But what do you think, Nang? She says, or Iris says, Kidney Foundation is also a great source of information. I think that's true.
Yeah. Thanks, Iris. I was also going to recommend the Kidney Foundation as well. So yeah, I think the more public education, the more public awareness. I mean, that was definitely one of the research priorities of the ATI. We are kind of in discussions about different campaigns that we might want to be a part of So those are also kind of in early discussions as well. But yes, public awareness and education is definitely high on the list for not only just the public, but also for potential recipients as well. Like, I think I'm speaking for me now. I personally think that there needs to be a culture shift in how we talk to patients with kidney disease. My impression is that maybe we start off by talking about dialysis and in terms of treatment options and treatment options. And so, I think what needs to I think what would be better if instead of talking about dialysis, that's the first treatment option, why don't we talk about transplant? It's the best treatment option for patients with kidney disease. And if we're talking about transplant, why don't we talk about living donor transplant? So even before we, start talking about dialysis, and do you want to do peritoneal dialysis? Do you want to do hemodialysis? Do you want to do dialysis at home? Do you want a fistula? Do you want a catheter? I think the first treatment option we should be talking to patients about is living donor kidney transplants, and then deceased donor kidney transplants. And then talking about dialysis. But that requires a culture shift and really promoting transplant and living donor kidney transplant to our patient population. That's just my thought.
I agree. And I think, all kinds of, I see Sean also wants to chime in. I was just to say, I think, especially for young people, I mean, I watch my kids, they're obviously, at a different stage of life, but people are getting information in so many different ways now, and it's great to have like specific sources of information. But I think if we really want a general public information, then it has to be through maybe some what we wouldn't consider typically traditional channels either. I think Sean has his hand up.
I know I'm the oddball being online and here physically in Calgary, but one question, I think, Anne, your presentation as well as Dr. Wang, your question to start off was around like donor burden and things like that. Is dropout of living donors because of the workup process a potential measure? And do you see potential from programs like Hamilton and Ottawa playing with the one-day living donor workup type of program? I go first. Go ahead.
Yeah, I mean, I can tell you that I would have been all over a single day workup if it had been an option for me. And as I said, I mean, I literally worked in the building where my workup was. So if there was going to be a less barrier or lower barrier workup for anybody, it would have been me. But even then, like, sort of saying, okay, I have to go to this appointment, then go to this appointment, or evening appointments or whatever for, to not have to take time off of work. Or if you have, a young child, you need to get someone to come, watch your children or whatever the case may be, or for shift workers. Yeah, I think it would be, it didn't stop me, but it was easy for me. So I don't know, Nang, do you hear that coming from other, like from your patients as well, your donors?
Yeah, I mean, I think in our databases, we are capturing how far donors get in the process. I don't know if we capture why they stop. Donors can stop for a number of reasons. One of it is the donor assessment burden, but donors could stop for a number of other reasons as well. And I don't know if our databases capture that or not. I don't know if you know.
We are. So I guess the question, in real life, at least in Calgary program, every year there's about 300, 400 potential donors going in. And at the end of the day, there are about 30 to 40 donation happening every year. So there's about, 90% of attrition rate. So with the available of Connect Care right now, we're trying to set up a dashboard to follow each step. Where did they drop off? What can we do to? Yes, yeah, good question.
And we do, I will say for the Calgary program, we do have a 1 day of testing. So donors can come to, I believe it's the foot, and they get their chest x-ray done, their CT angio done, and their nuclear medicine scan done all in 1 day. So those aren't separate tests. The 1 day testing would also, the ones that have been done in McMaster and in Ottawa would also in the afternoon have appointments with social worker and nephrologist and surgeon. We currently don't have that, but I think the 1-day testing is a good start. And yeah, we're also looking to always improve our donation assessment process as well.
I just put a comment in the chat too that, I think for some donors, the transition from being a directed donor for somebody to going into a kidney paired donation cycle might also, I don't know what the right word is, like worry them or be a barrier or sort of a place where they say, you know what, I don't want to donate through that channel. And if that's something that you see on, as a nephrologist as well, if that comes up, because for me, that was not an issue. I understand KPD, I know what it is, and it can increase your time though, right? Like maybe you have a little less flexibility when things happen for you, which for some people might be a barrier. But for me, I actually was happier to do it that way in a way, because I hope that it meant a better match. Or, I don't know if we always do this too, but I know my typing, I said, can you run me against the highly sensitized registry also, which maybe most anonymous donors don't ask. But, even those kinds of things, is that something that you hear as clinicians, that people don't necessarily want to donate through paired exchange if they're not a match to their directed person?
Yeah, I think I will say, we sometimes recipients or sometimes people go through social media or billboards and can lead to a lot of people calling in to, interested in living kidney donation. And I would say, having worked at both programs now, the donor coordinators are amazing, and they do talk to potential donors about, if you're not going to be a directed donor, there is this other option, and do talk to them about the logistics of that as well. As you mentioned, the pros and cons in terms of, potentially longer wait time, but also the potential benefit where you could start chains and help, more than one person, 2 or 3 people as well. And so, our donor coordinators do talk to people that call in about that. And I think we have had anonymous donor or people call in for a directed donor who then, can't donate. So then they become anonymous donors and have started KPD chains. And I think that is a lot of that success is because of the amazing donor coordinators that we have.
Yeah, Iris added a comment on this saying that, KPD isn't for everyone, that they educate on pros and cons of this and ask every donor for their interest in that.
And after the COVID, we do have like the culture shift. Used to be like, the donor has to travel to different, to the donation center. And they were shipping the kidneys rather than let the donor to travel.
Yeah, I was really, really happy I didn't have to do that. I'm not really supposed to know exactly where my kidney went because of all the forms I had to fill out for COVID. I kind of do know that it was another province, and I wouldn't have wanted to travel. I mean, it was really nice to just be at my local place with my village and not have to worry about getting on a plane or traveling while I was recovering. That was a huge benefit. I would have done it, but I was really happy I did not have to do it. So I think that was another COVID silver lining.